This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome. This is Greg Cooper from the Norton Neuroscience Institute in Louisville, Kentucky. I'm speaking today with David Wolk of the Perelman School of Medicine at the University of Pennsylvania about his paper published in Alzheimer's and Dementia titled Clinical Criteria for Limbic Predominant Age-Related TDP43 Encephalopathy. David, welcome to the podcast.
Thanks so much for having me.
So I hoped you could start out by telling us just a little bit about the history of this condition. I guess we commonly refer to it as LATE, L-A-T-E.
This is a condition that is related to a particular protein, in this case TDP43, that was really first recognized in around 2006 or so by Manuela Newman, Virginia Lee, really in association with ALS and some forms of frontotemporal lobar degeneration. And in the ensuing years, it became more and more recognized as something that was quite common in older adults, as well as quite common in the context of Alzheimer's disease. And moreover, a lot of work done by a number of different groups, including a group at Mayo, at Kentucky, and at Rush University, I think really nicely mapped out that there's a relationship between this age-related TDP43 pathology and aspects of cognitive decline, so memory in particular, as well as predominance in limbic structures of the brain. And so when you put it all together, it actually describes that acronym, which is limbic predominant, because that's where the TDP is, age-related, because it tends to occur late in life, TDP43, because that's the protein that defines it, and encephalopathy, because they needed an E to make it sound out something, and that was the best choice at the time.
I feel like, showing my age a bit, perhaps, this is a clinical entity that we may have recognized in the past. And in fact, I remember my mentor, Bill Marksbury, referring to it as the simple form of Alzheimer's disease. I think recognizing even himself it wasn't Alzheimer's disease, but we didn't really understand it before we could do staining for TDP43. Is that correct, or am I off base?
At least there was some recognition of one of the manifestations of this, which are, from a clinical standpoint, patients that have a primarily amnestic presentation that doesn't seem to evolve as quickly or involve other domains as severely as Alzheimer's disease does. Pathologically, there was an entity called hippocampal sclerosis, which is different from the sclerosis that we talk about in the context of epilepsy, where it was recognized that those individuals had really severe atrophy and neuronal loss, particularly in a part of the hippocampus called the CA1 subfield and subiculum to some extent. And those individuals tended to have significant memory loss. And Dennis Dixon really was the first person to describe that in the 90s. And it turns out that late is very commonly the pathologic entity associated with hippocampal sclerosis.
So it's likely when we were making a diagnosis 30 years ago of hippocampal sclerosis, we were really recognizing this entity, but just didn't have a deep understanding of it.
Yeah, I think that's the case. And I would just say, though, that hippocampal sclerosis is probably the more severe end of this condition. And so there's probably a continuum from that to more kind of mild forms of the condition, both with regard to the degree of injury to the brain and the degree of symptoms that tend to be associated with that. But yeah, no, I think we have seen those cases. There have been a number of cases that I've seen over the years where I thought they had Alzheimer's disease before we would tend to get biomarkers, and then just noticed that they just never seem to get much beyond significant memory loss. And in retrospect, also, I've been like, oh, a number of those cases actually had late before we even defined that condition.
We perhaps haven't done as good a job as we might of recognizing this in the past. Tell us a little bit about why this is important to recognize now. The prevalence is really much higher than most of us probably realize.
Yeah, so I think there are a few reasons why it's really important to think about this condition. One is, as you say, it's a very common condition as people get into their 80s and beyond. upwards of 25% of individuals can have late. And so it's a very common late life form of memory loss. I think it's important because it's also, as a result of that, a mimic of Alzheimer's and often something that is in the differential with patients with Alzheimer's. And that becomes even more important now as we enter, a more therapeutic era with Alzheimer's, is that one, we're now determining who has Alzheimer's versus who doesn't based on biomarkers. And so late is often going to be the condition that they have when they don't have Alzheimer's. And then I think another really important aspect of this condition that we need to think about more is the fact that it co-occurs with Alzheimer's very frequently. Depending on the study you look at, up to 50% of patients with Alzheimer's disease have some degree of concomitant late, and it very clearly affects the trajectory of the disease in those patients. So those individuals tend to have a more rapid decline, and that may influence how drugs that are targeting specific aspects of the biology of Alzheimer's disease may work in what their efficacy is. And I think this disease plays a big role in just normal aging or aging in people who are having cognitive symptoms, but also I think it's an entity to think a lot about in the context of Alzheimer's disease as well.
I think that helps lead us into really what I consider the core of this paper. Tell us a little bit about the core clinical features that we are likely to see in late.
These criteria were developed by consensus with a number of experts within the field. And really the attempt was to try to put a flag in the ground to define better how we can classify patients with this condition, knowing that this is the first step for us to better understand and detect this condition in living patients, because almost all of the work in late has been done really from autopsy series going back and looking at individuals during life. And so this was really an attempt, how can we better classify these patients in a more consistent way while patients are alive? And the most typical feature is a pretty slow moving course where individuals have amnestic features, so forgetfulness, short-term memory failures. They can have some degree of language impairment, sometimes more semantic types of language impairment. So for example, individuals might have more difficulty on a kind of cognitive task like category fluency. Tell me the number of animals you can think of in a minute, versus lexical fluency, which is tell me the number of words you can think of that begin with a particular letter. So some aspects of semantics are affected in part because of where the pathology is. It moves into the temporal pole near limbic regions. It tends to occur, as the name says, in late life. It tends to occur in people 75 and older, can occur probably earlier than that, but is much, much less frequent and is much more frequent as you get into your 80s, late 80s, and 90s. One of its features tends to be its slowness. People will have noted memory issues for a number of years come in, and they'll continue to have memory issues for a number of years after. So it moves more slowly than typical Alzheimer's, for example.
Based on that, would the primary differential diagnosis we're considering be Alzheimer's disease?
I think in someone where late is the driver of their symptoms, generally the condition that it's going to overlap with the most is Alzheimer's disease. Of course, memory can be affected in a variety of different ways, from things like vascular cognitive impairment, and even conditions like Lewy body sometimes will have some degree of memory impairment, often on an attentional basis. But there'll often be other features that in those other conditions that distinguish from late. And so generally, really late and Alzheimer's disease would be the two things that are most likely. There's some other rarer conditions that are sometimes within that differential as well.
And based on what you said, I think you already answered this. We would typically be thinking of a lower age cutoff of about 75 years, generally 75 years and older.
When we set these criteria up, we wanted them to be obviously somewhat sensitive, but in particular specific as we can be with clinical measures to late. And really 75 and older increases the likelihood that we're correct in that diagnosis. And again, I think the older you get, the more confidence you can have in that diagnosis, even beyond 75.
In particular, Figure 1 really shows an excellent algorithm. Table 1 gives a good listing of the clinical criteria. Could you speak just a bit to the use of biomarkers in this diagnosis?
Yeah, right now there is not a molecularly specific biomarker for TDP43. There might be some on the horizon. So the diagnosis is somewhat inferential from a variety of features. And that's something those of us who have been in the cognitive neurology field and studying neurodegenerative disease are quite used to for years. That's basically been the way we've diagnosed individuals, as somewhat probabilistically based on their cognitive features, and then some other biomarker features that might help us in distinguishing the condition from others. And so one biomarker that is core to the criteria is having hippocampal atrophy. These individuals almost always have a significant amount of atrophy within the medial temporal lobe that often is somewhat actually disproportionate to their degree of memory loss. So their hippocampi look worse than what you might even expect given where their memory is. And I think some of that may have to do with the fact that TDP43 has this ability to basically, when there's pathology there, the cells die off and disappear. And so that creates more severe atrophy than you might see with like tau pathology per se. So that's one feature that, again, to make it more specific, we required. Are there some cases that don't have a lot of hippocampal atrophy yet that you can see on a scan that might have late? Certainly possible. And then the other really big biomarker that we include in this is a biomarker of amyloid, and really to rule out Alzheimer's disease, because once you've ruled out Alzheimer's disease in these cases, and in rare instances, there may be other conditions that sometimes can be associated with hippocampal atrophy and this kind of memory phenotype. But it's really limiting the numbers to being much, much more enriched in patients who have late at that point.
If I read this correctly, then if you have the right clinical phenotype and your biomarkers are negative for amyloid, you probably have a pretty good level of confidence that would qualify as probable late. Where it gets very difficult is if you do see evidence of amyloid, and I think you next want to move to some type of measure of tau. Is that correct?
Yeah, so this is definitely where it starts to get more complicated. Tau in Alzheimer's disease is very tightly linked to downstream atrophy, neurodegenerative changes in the brain, and cognitive changes. And the case that there are many cases with amyloid in the brain that don't have enough load of tau pathology for us to see on tau PET. And generally, if there's not enough tau pathology to see on something like tau PET, it's unlikely that if you have atrophy, that tau and Alzheimer's is what's driving that atrophy. And if you had evidence of amyloid, but you didn't have significant evidence of tau pathology and still have the phenotype that we described earlier with a small hippocampus, we call that possible late, where we think many of those cases likely have late, but we're a little tentative because there's some argument about what the sensitivity is of tau PET, of early tau pathology that could have some of these downstream effects.
I was also intrigued with the use of FDG PET. Can you say just a bit about that?
Yeah, so as a cognitive neurologist, I think FDG PET is an extremely useful tool just in general for our differential diagnosis. It has a way of bringing out patterns that differentiate conditions. And so actually, Dave Jones at Mayo Clinic has done a lot of work with development of signatures of FDG PET for late or for concomitant TDP43 pathology. And basically, in cases that don't have Alzheimer's disease as the driver of their symptoms, you don't get with late that posterior temporoparietal hypometabolism of Alzheimer's disease. And what you do get is significant hypometabolism really in the medial temporal lobe and into orbital frontal cortex. And so unlike Alzheimer's disease, I guess sort of two features of FDG is useful. One is the absence of an AD pattern. So for example, again, in a case that's amyloid positive, let's say you didn't have tau PET. If you don't see an AD pattern, an FDG PET, that probably argues that there's not a lot of downstream effect of tau pathology at that point, and that something else is likely the driver of your symptoms if you come in again with the phenotype we're talking about. But also, so that's sort of the exclude AD part of FDG PET, but there's also an include late part of it, which is where you tend to see pretty focal hypometabolism. And what the group at Mayo had developed actually was a ratio where if you look at the relative metabolism in inferior or lateral temporal areas to the medial temporal lobe, or if you also include orbital frontal cortex, you'll see that there's a much greater discrepancy in late cases than in AD cases, where the temporal lobe more broadly is affected and the ratio is closer to equal, whereas with late, it tends to be much more focal in those instances.
And I would imagine that could be quite useful. Most of us are not going to have access to tau PET, but FDG PET is something many of us could get access to, I think.
Yeah, so I think FDG PET is definitely a tool that is much more amenable to clinical use. I do think it requires a little bit of work to get familiar with the pattern we do see in late, because it's not something I think most of neurologists are used to looking at, or radiologists. But again, even alone, the ruling out of an AD pattern in these cases, I think can be really useful. So if you have someone with hippocampal atrophy, memory loss, 80 years old, and that you do an FDG PET and they don't show temporoparietal hypometabolism, that in of itself, I think, pushes you again more into the late camp.
Excellent point. So we've talked quite a bit about the clinical criteria. Do we know much about how the underlying pathophysiology is driving this? What is TDP43 doing?
Yeah, there's still a lot to learn about what the driver is of TDP43 related neurodegeneration, not just in late, but also still in ALS and frontotemporal lobar degeneration. TDP43 is a DNA and RNA binding protein and is involved in regulating splicing of RNA. And basically, it generally sits in the nucleus, although it can shuttle back and forth between the nucleus and cytoplasm. And what happens in these diseases is there tends to be aggregation of TDP43 in the cytoplasm and loss of TDP43 in the nucleus. And so there's some debate about the degree to which TDP43 pathology reflects either a loss of function, which is no longer doing its sort of maintenance of DNA, RNA, and you actually do see cryptic splicing of RNA that's not spliced in its correct way, and even cryptic peptides, where peptides are formed based on this missplicing in these individuals. So it could be a loss of that function, or it could be a gain of function of the aggregates themselves, resulting in injury to the cells and loss of their function. And it could be both. And I think there's still a lot to learn about it. In the context of Alzheimer's disease, there also seems to be some synergy or interaction between TDP43 and tau pathology. Oftentimes, they're both in the same neurons, and there tends to be higher tau loads in patients with concomitant late. And so there may be greater complexity to the biology of these proteinopathies in terms of how they interact as well. So still a lot to learn.
I think you put it very nicely that this is a first attempt to put a flag in the ground. And to me, the great contribution here is we're taking a pathologic entity and bringing it into the clinical realm. Can you say what you think is next? Where is the field going from here?
One is, I think the better we can define this clinically, the better we can describe its phenotype and link its biology to individual patients. And I think until you get to the point where you can identify a disease during life, it's very difficult to study the disease in the scale that we need to study it. It also allows you to conceivably do clinical trials or other kinds of intervention studies. It also allows you a population of which to develop additional biomarkers and other tests to learn more about the condition. I think that the most important thing that needs to occur, though, is the development of much more specific biomarkers for this condition. I think there's work in using, again, more inferential types of measures with imaging, with other kinds of existing biomarkers, but really we need biomarkers for TDP43 that are much more specific. And I think there are some promising avenues towards this, particularly with regard to biofluids. Those cryptic peptides I mentioned earlier that are created when this protein is dysfunctional is one thing that has been detected in tissue and in CSF and even to some extent in blood, and could be a marker of this condition as the technology improves for detecting them. There's some work looking at extracellular vesicles that can be measured in blood that are brain-derived, that there's at least some hints that TDP43 can be measured there as well. I really think, though, that the next phase of this field requires us to come up with those sort of molecularly specific biomarkers so we can add to the sort of compendium of tests that we have for Alzheimer's disease and other neurodegenerative conditions.
Well, I think this will be an exciting area to watch over time. So it's been a great pleasure talking to you today. Again, it's been our privilege to hear from David Wolk of the Perelman School of Medicine at the University of Pennsylvania about his paper published in Alzheimer's and Dementia titled Clinical Criteria for Limbic Predominant Age-Related TDP43 Encephalopathy. David, thank you.
Thank you so much. It was fun.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.